everyone. My name is Helena Yu. I am a thoracic medical oncologist that is based in New York City in the US, and I work at Memorial Sloan Kettering Cancer Center. We are very excited to present this modular activity. There's a lot of new data for non-small cell lung cancer that has emerged in the last few years, and there is a particular interest in EGFR-mutant lung cancer with some of the new data. So the first module of our course will focus on EGFR-mutant lung cancer. We will review unmet needs, what are the latest advances, and then also provide some practical insights. Module 2 will be reviewing EGFR wild-type non-small cell lung cancer, again going over unmet needs, the latest advances, and some practical insights. And then finally, Module 3, bringing it together for optimal care. We will review patient management of a variety of patients, go over the biomarker landscape, as well as summarize our key learnings from the different modules. So that's a great question. There are actually a lot of unmet needs in EGFR-mutant lung cancer, despite some recent new advances. I think one thing to initially discuss is that not all EGFR mutations are the same. The two common mutations that we see are exon 19 deletions and L858R point mutations. And the majority of clinical trials really focus on these two common EGFR mutations. But there is less data about some of the uncommon mutations, which include exon 18 mutations like G719A or G709, S768I, or L861Q. So those mutations were not enrolled onto the prospective clinical trials we will be discussing in this module. And so understanding what the ideal treatment strategy for those is certainly an unmet need. I think another unmet need is that EGFR mutant lung cancer is actually quite heterogeneous. We see many patients with EGFR mutant lung cancer, treat them with the same therapy, but their outcomes are quite different. Some patients respond exceedingly well to single agent EGFR TKI for many years, and there are others who don't respond to therapy. So identifying appropriate biomarkers for us to be able to risk stratify patients and then ultimately provide risk adaptive treatment strategies is a clear goal for the future. And then importantly, patients all or mostly all respond to EGFR inhibitors, but this is not durable. Everyone ultimately develops resistance to EGFR TKIs. And I think a challenge here is that the resistance mechanisms that we see are actually quite heterogeneous. We can see on-target mutations or on-target resistance, which are acquired resistance mutations in EGFR. We can see off-target acquired alterations, which might be MET amplification and acquired gene fusion, like an ALK fusion. And then we also see more commonly, actually, with osimertinib, in about 10 to 15% of cases, we see histologic transformation. And that's when a tumor that previously was an adenocarcinoma transforms to either squamous cell lung cancer or a small cell lung cancer. And then for about half of patients, we actually don't have a genomic based mechanism of resistance that's easily identified. And how to treat those patients or all of these patients really is not clear at the moment. And I think another important unmet need is further targeted therapies. As of now, we do not have an approved targeted therapy that is available after first-line osimertinib. And so understanding what treatments might be effective in that space is a critical unmet need as well. And then finally, about more than half of these patients will ultimately develop brain metastases or leptomeningeal disease. And these are sites of metastatic disease that certainly have a lot of morbidity and mortality for our patients. And so understanding, for novel therapies, how effective are they in the central nervous system really is a key thing for drug development in this space. We are grateful that there actually is a lot of exciting ongoing research in EGFR mutant lung cancer. As I mentioned, resistance mechanisms to osimertinib are quite diverse, and so will require diverse novel therapeutic strategies for overcoming resistance. So there are certain identified mechanisms of resistance like MET amplification or an ALK fusion where we can, add perhaps a different targeted therapy to osimertinib to help address that specific resistance mechanism. But also what to do for the majority of patients where we don't have an identified mechanism of resistance and how to best manage those patients is an ongoing research focus. Another area of active research is combination therapies in the first-line setting. But a big question is, does everyone need combination therapy? Or would there be patients that would be treated best with single-agent EGFR TKI? And can we identify biomarkers that help us risk adapt and risk stratify our treatment? And then the idea of how to best manage central nervous system disease and leptomeningeal disease. Unfortunately, a lot of our clinical trials of novel therapies exclude patients with active brain metastases or leptomeningeal disease. But the efficacy of novel therapies in the central nervous system really is a critical piece of information that will help us guide patient management in the future. And then, of course, I think diversity in clinical trials is really critical because we need to understand from our clinical trials how these novel therapies will benefit our diverse patient populations. And so understanding how generalizable results from clinical trials are is a key area where we need to look into further. So I would focus the key emergent studies in two areas: the clinical trials that are focused in as first-line treatments, and then different strategies in the second line and beyond. And so in the first-line setting, it really is looking at combination therapy that is based on either osimertinib or a novel third-generation TKI like lazertinib. And so the idea is, what partners can we partner with EGFR TKIs to enhance both the number of patients that respond, but also the durability of response, and probably most importantly, improve survival in the long run for these patients. And so different partners include chemotherapy, antibodies like amivantamab that target EGFR or MET, or VEGF antibodies like bevacizumab. And there are studies ongoing with all of those agents. And then when we think about clinical trials in the second line setting, it really depends on what patients received in the first line setting. So for the standard patient who receives a single agent TKI as first line treatment, then many of the different combinations in the second line setting focus on chemotherapy, which really is the standard of care second line therapy. And so adding perhaps amivantamab or ivonescimab to chemotherapy. And then there are novel targeted therapies like ADCs, which are being assessed in this space. And that might be patritumab deruxtecan, which is a HER3 ADC. And there are a few fourth generation EGFR inhibitors that are being looked at post-osimertinib as well. So a very active area of investigation, both in the first line setting and in the second line setting, which of course we will hear about further in some of our other modules. Hi, everyone. My name is Helena Yu. I am a thoracic medical oncologist at Memorial Sloan Kettering Cancer Center in New York, New York. Today, I'll be discussing with you all a patient case. Our patient is a 55-year-old female. She is of a Hispanic descent, and she works as a teacher presently. She's a never smoker, and diagnostic workup identified a lung adenocarcinoma, and staging of her cancer identified metastases to the pleura, the bone, and the lymph node. Molecular testing was done on her biopsy sample, and she was found to have an EGFR exon 19 deletion in her cancer. She did present with symptoms. She had shortness of breath due to a pleural effusion, and so far she has not been treated for her cancer. So this is a pretty typical case. We know that EGFR mutant lung cancer is enriched in never smokers. The patients tend to be younger, with less comorbidities. And she presented with symptoms, and she presented with stage 4 disease. So more than half of patients with a new diagnosis of lung cancer will have stage 4 disease. She has symptoms that need to be ameliorated. And she has a common EGFR exon 19 deletion. So one of the common sensitizing mutations where the different studies did focus on assessing this cancers with these mutations. And so really the backbone, I would say, is treatment with osimertinib. We know that osimertinib is the newest third generation EGFR inhibitor. We do have earlier generation inhibitors, but certainly for single agent therapy, I really would only give osimertinib. And then the real question with emerging data is this a patient where I would want to escalate treatment? I would say that my current practice for most patients is to just proceed with osimertinib monotherapy. We know that that osimertinib can work extremely quickly, where it can improve symptoms in a matter of days to weeks. And we know that it is quite effective with a prolonged progression-free survival and overall survival. And so for the average person that is diagnosed with EGFR-mutant lung cancer, I would proceed with osimertinib, but there are nuances to different cases that might make me decide to escalate care. So to decide on combination approaches, I probably would need a little bit more information on this patient. She is symptomatic, and so obviously we would like to see a robust and rapid response. Along with the EGFR mutation, I would wonder about different co-mutations. So we know that patients that have concurrent TP53 alterations, which is almost 2/3 of patients with EGFR mutant lung cancer, or patients with RB alterations, do have poor outcomes with single agent EGFR inhibitors. So knowing about the co-mutation status might push me to combination therapy. And then, knowing about ctDNA status. And so we know that patients that have baseline detectable EGFR ctDNA in their plasma, or if after 3 weeks of osimertinib therapy, they have persistent EGFR ctDNA, both of those are biomarkers for shorter and inferior benefit with single agent osimertinib. And then there is also some data on sites of metastatic disease. So perhaps if a patient has brain metastases, we saw some really compelling data from FLAURA2 that's adding in chemotherapy to osimertinib, that combination might be particularly effective in addressing CNS metastases. And I think we do have choices here. The two main choices that we either have presently or we hope to have in the near future is adding chemotherapy to osimertinib based on the FLAURA2 data, or considering amivantamab and lazertinib. So amivantamab is the EGFR MET bispecific antibody. Lazertinib is a different novel third generation EGFR inhibitor. And both of these showed significant improvement in outcomes, specifically progression-free survival with the combination, but we don't have overall survival data for either of these. And I think that would be the key, is when we consider treatments that could be sequenced, that could be given sequentially, if we're combining them, I want to see an improvement that is greater than the sum of benefit from the two separate therapies. And so we really would want to see an impact in overall survival. So after I met this patient in clinic, and based on a discussion on her goals and sort of her desires with her care, we decided to proceed with single agent osimertinib. She did great with therapy. She tolerated 80 milligrams of osimertinib daily well, with really minimal side effects. She had a little bit of dry skin, a little bit of upset stomach, but really was able to maintain that dosing throughout her treatment. Her symptoms almost immediately improved, specifically her shortness of breath. First scan showed excellent response to osimertinib, and she did well for about 1.5 years. And so at about a year and a half on treatment, we did restaging scans, including CAT scan of the body as well as an MRI of the brain. We did see some new brain metastases that were not present previously. So I think second line is becoming more and more involved as well, especially with the different options that someone has in the first line setting. And so I think to go down two possible scenarios, if someone receives first line osimertinib monotherapy, I think there are quite a few options in the second line setting. The standard of care in this space would be platinum doublet chemotherapy that's based on histology, so typically carboplatin and pemetrexed. But now we have data that we potentially could add different things to chemotherapy in the second line setting. And I think the most notable addition to standard chemotherapy would be the addition of amivantamab, that EGFR MET bispecific antibody, to chemotherapy based on the Mariposa 2 study. Another thing that we could potentially add to chemotherapy would be a VEGF inhibitor or also a PD-1 inhibitor. And so one that combines both would be ivonescimab, which is a dual PD-1 and VEGF antibody. We do have data from various prospective studies that just adding immunotherapy a la nivolumab or pembrolizumab to chemotherapy really did not seem to be helpful in this patient population. There was no significant improvement in progression-free survival or overall survival with the chemo-immunotherapy combinations. And then there are some novel therapies, in particular, antibody-drug conjugates. And so one antibody-drug conjugate that has been looked at significantly and comprehensively in EGFR-mutant lung cancer is patritumab deruxtecan. That is a HER3-directed antibody-drug conjugate. And there are data suggesting its use potentially after chemotherapy and EGFR inhibitors, but ongoing studies that are looking at it as well immediately after osimertinib. So right now, this patient has various options, but I think in the near future, there will be more complexity in the various options that we might have for her. So hearing the different options that my patient had both in the first line setting and the later line setting really is indicative of the quickly changing landscape in this space. And I think, the decisions we make for treatment for our patients in the first line setting, of course, affect their options in the second line setting and vice versa as well. So, there are ever-changing new therapies that are also being looked at, and we look to upcoming congresses that might provide new data, but it really is key to continue to follow closely new data as it comes out, and in particular, I think interest in figuring out what would be the appropriate biomarkers to help us pick which patients for which different combination therapies, I think is an unmet need that will be answered in the near future.
Hello to everyone. I'm Antonio Passaro from European Institute of Oncology in Milan, Italy. It's a great pleasure for me today to discuss with you the latest advance in therapeutic strategy for patients with non-small cell lung cancer harboring EGFR mutation. So we select the most important data from the phase 3 and phase 2 trial that was published or presented in the last 12 months, considering the clinical impact in this particularly biological field of patients with non-small cell lung cancer EGFR mutation. So, and the first question for our presentation is what do the latest clinical trial tell us about the combination strategy and first-line setting for this kind of patient population? And the first trial that we discussed today is the FLAURA2. The FLAURA2 is a randomized phase 3 trial evaluating the combination of platinum-based chemotherapy, carboplatin pemetrexed, plus osimertinib versus osimertinib alone in patients with EGFR common alteration, exon 19 deletion, exon 21 mutation, And the results that was previously presented in World Lung Cancer Congress and then published in the New England Journal of Medicine show that the combination of chemo plus osimertinib was statistically significant, positive in favor of the combo versus osimertinib alone. And we can see here in the slide that the median progression-free survival for the combo was 25.5 months versus 16.7 months. Globally, around the subgroups analysis for alteration, there we can see that the benefit was consistent for all patients evaluated in the trial. And impressive, we can see that the combination was very, very active in those patients that showed the presence of brain metastasis. Indeed, in the trial, a patient with a stable CNS disease was randomized. So the other ratio for disease progression of that for patients with no CNS metastasis was 0.75. We can see that the safety evaluation showed, of course, an increased rate of grade 3, but this is quite common for all the combination approach versus more or less 30% of grade 3 for osimertinib alone. The second phase 3 trial in first-line setting that was previously presented during ESMO 2023 and later published in New England Journal of Medicine is the Mariposa trial. The Mariposa is a phase 3 trial evaluating the combination of amivantamab, a bispecific antibody targeting EGFR and MET, plus lazertinib, a third-generation inhibitor for EGFR, versus osimertinib. And also there is a third arm for lazertinib alone to evaluate the consistency of the components. So in the trial, as in the FLAURA2, were enrolled a patient with a common alteration, exon 19 deletion, exon 21 point mutation, and patients with stable CNS disease were enrolled. The results for progression-free survival was very, very interesting. It showed a significant improvement in progression-free survival for the combination of amylase versus osimertinib, with 23.7 months for amilazertinib and 16.6 months for osimertinib alone, with a reduction on disease progression DEX by 30%. And interestingly, we can see that the progression-free survival was achieved, it was a consistent benefit across all the subgroups, age, gender, race, and also different kind of EGFR alteration, in particular also patients with brain metastasis. As discussed for FLAURA2, when we try to combine different agents, this is the time to increase toxicity, that we know this is a kind of limitation. And here we can see in the same way for FLAURA2 that the greater combination show with our grade 3 adverse event 75% versus 43% for osimertinib alone here. But interestingly, recently, after the publication of Mariposa, Enriqueta Philippe, during the ASCO and later published in the Annals of Oncology, reported the analysis of high-risk subgroups in the Mariposa trial. So we identify patients with a high-risk subgroups with the detectable ctDNA, the presence of co-mutation for TP53, brain metastasis, liver metastasis, also persistent ctDNA after the third cycle. And in all these kind of subgroups, we can say that there was a consistent benefit for the combination of amivantamab plus lazertinib versus osimertinib alone. And in my opinion, the most important thing here is related to the commutation of P53 that we know in clinical setting is a very orphan setting for patients with this poor prognostic factor for considering the EGFR patient population. The second part of the presentation will focus on those trials that show very interesting results after osimertinib, so in the setting of resistance mechanism. In the setting of a resistant mechanism, one of the most interesting trials is a phase 2 trial, the Helena-Lung-1, that evaluate the efficacy and safety of a new kind of cancer therapeutics. Here we are discussing an ADC, patritumab deruxtecan anti-HER3 ADC with the deruxtecan as a payload that was evaluated in the patient progressing after osimertinib after platinum chemotherapy, so in third-line setting. Also here, patients with a common alteration were enrolled, and also patients with a brain metastasis were included in the trial. So we can see that in third line, the monotherapy of patritumab showed an eternity over response rate of about 30%, in particular 29.8%. And globally, the results suggest a very interesting efficacy of these agents that at the present time is ongoing, is a confirmative phase 3 trial, the EFTINA-Lung-2 in second line after osimertinib in comparison with platinum pemetrexed. When we focus on the safety of these kind of drugs, that the EFTINA-Lung-1 was evaluated in 225 patients, we can see that globally the rate of grade 3 or more was 64.9% versus and the grade 4 was 28.9%. But in my opinion, the most critical point to evaluate and deeply consider also the EFTINA-Lung-2 would be the rate of ILD that could be considered as a critical point for the development. But balancing efficacy and safety, this could be considered a very new kind of opportunity within the phase 3 confirmation trial. Continuing the setting of the resistance mechanism, of course, now is the time of the Mariposa 2 trial that I was pleased to present during the last presidential ESMO 2023. And we can see here the primary results focusing of the combination of chemotherapy plus amivantamab versus chemotherapy alone. At the beginning of the trial, there was also a third arm with the chemotherapy plus ami plus lazertinib that showed a very critical point considering the safety. When we focus on the efficacy and the safety of the trial, we can see that globally, the combination of ami chemo showed a very significant reduction in hazard rate for disease progression of death for patients randomized to receive chemo plus ami with a value of 0.48 with a progression-free survival of 6.3. And globally, these results was interesting, but not so much as the results of intracranial progression-free survival. Indeed, in the Mariposa 2, patients with brain metastases were low, and definitive radiotherapy was not required for patients enrolled in the trial. And we can see that intracranial progression-free survival was a statistically improved for patients candidates to receive the combo with a 12.5 months for ami chemo versus 8.3 months for chemotherapy. Of course, as I discussed before, for Mariposa and FLAIR-2, when we combine most strategy, of course, is the time to increase the rate of toxicity. And also here we have a more or less 70% of grade 3 toxicity. When we focus also in the development of amivantamab, it's very interesting to discuss the results of the Paloma 3. During task, Natasha Lay presented the preliminary analysis of Paloma 3 that later we published on JCO, and we can see that the Paloma 3 was a randomized phase 3 trial that compared the amivantamab IV plus lazertinib versus new formulation, amivantamab subcut versus plus lazertinib. In this particular trial that evaluated as a primary endpoint, the PK, we can see that it was an equal PK for ami chemo, ami lazertinib IV versus ami subcut plus lazertinib. Among confirmatory response, the median duration of response was 11.2 months in the subcutaneous setting, with also no statistically significant improvement in the progression-free survival, and very interesting for also in the overall survival. Globally, the trial showed a very important point. Using subcutaneous injection of amivantamab, we reduce the rate of infusion reaction. So we have 13 rates for subcut plus lazertinib versus 66 for IV. And based on these results, EMA now is evaluating the approval of ami lazertinib for the first line directly with the subcut versus IV. That is a great opportunity. So finalizing my discussion of the new, very interesting data in the field of EGFR non-small cell lung cancer, always during the ASCO was the time of the Harmony trial. The Harmony trial, that in this analysis was focused only on Asian patient population, evaluate a new combination of a bispecific antibody evonescimab, that is a bispecific antibody targeted PD-1 and VEGFR, compared to standard chemotherapy with platinum pemetrexed after TKI progression. And here we can see that the combination showed a very interesting improvement in progression-free survival, with a progression-free survival of 7.1 months compared to 4.8 months for the chemotherapy alone. And globally, the safety was similar across the two arms, with we can see with the grade 3 that were 54 for the combination and 42 for the chemotherapy alone. And there was a very significant increase of immune-related toxicity or EGFR-mediated toxicity. So very interesting data. And at the present time, the Harmony trial is ongoing in the Caucasian patient population, enrolling patients and finalize the enrollment, I think, by the end of September. So globally, all these results confirm that the way to improve the management of patients with non-small cell lung cancer harboring EGFR alteration is a very exciting moment. We have a very important results in first-line setting with the two different combinations, one with the chemo plus OSI, the other with the amivantamab plus lazertinib. And we have a different kind of strategies ongoing already to arrive also in the clinic in the fertility setting and resistant setting, where at the present time, the only new waiting for the EMA approval, already reported the NCCN guideline, is the combination of amivantamab plus chemotherapy related to the Mariposa 2 study.